Thanks, Scott and Matt, for inviting me to talk about expandable cages, some of the pros and cons and relevance. I think if you could, the bigger you can keep that, the better. My eyes are probably worse than Wellington's. And so I appreciate and thanks Paul and Wellington for introducing a lot of the topics that I'm going to quickly summarize in my talk as well. But these are my disclosures. None are relevant to any cage design or anything that we're going to talk about today. And I'm just going to start with a case, and I think this case kind of highlights a lot of what Paul was talking about in regard to how we treat patients with older patients with osteoporosis. I think as we all are treating more patients as they age, we have to be very mindful of bone health and quality, and this is a great case for everyone to kind of think about as we sort of talk about expandable cages and talk about sort of what our options are. But this is an 85-year-old female. She presents with bilateral L4 radiculopathy. She's and neurogenic claudication. She's super active, very healthy, thin. And you can see there, she's got a grade 2 spondylolisthesis at L4-5. And this is her standing film, well balanced, overall alignment looks good. And this is her MRI, which shows very focal disease at L4-5, significant stenosis both foraminally at L4 as well as centrally, causing mostly L4 radiculopathy and some neurogenic claudication. And so think about that as we sort of talk about some of these interbody cage designs, and especially, and obviously I'm going to focus on expandables, but as we start to think about some of the generalities of interbody cages, I'm not going to go through this again, but there's a lot of different options out there. I think about that with titanium, these sort of old versus new school titanium. The old school is that block of metal that you couldn't see through with the super high modulus of elasticity. The newer school titaniums, the 3D printed versions, are much more, in my opinion, used so that we can see through them. Fusion rates are great, as Wellington went through. And then finally, expandables. And as we sort of think about the differing scenarios of how we use them and how I decide what I'm going to use, it all comes down to, degenerative versus deformities, osteoporotic patients, as well as tumors and infections. And Wellington showed a really nice case where surveillance would be very important in patients. And so, using some other materials like bone, allograft, or even PEEK in tumors can be very helpful. And really, when expandable cages came out, I generally used them to fill defects. I did not use them for degenerative principles. I didn't really like the concept. I'm a late adopter to technology, and so I used them initially just to fill defects. And as you'll see in some of the cases I show, I've sort of matured in a way, especially with my younger partners like Dr. Spina. He was like, why are you still using these static things? So I felt like an old guy. So I started using these expandables. And as we talk about these expandables, you have to think about what you want from an interbody cage. But I think with expandables, they become a much more technically difficult surgery. You have to be a lot more careful with end plates, as Paul was talking about. You have to be really careful with how you expand them, careful with compression and distraction through your screws, and we'll go through some of that today as well. But in general, interbody cages, we've talked about a lot of this already. You want it to be relatively inert. You don't want an inflammatory response to the material. You want adequate room for graft. You want it to be inserted in a stable fashion. You want it to be a tough material so it doesn't break when you put it in. You want a, favorable modulus of elasticity is questionable, and I'll show you a biomechanical study showing some reasons as to why I say that. But definitely osteoconductive nature, you want it to be hydrophilic, not phobic. PEEK in general is a very hydrophobic material and one that I rarely use. You want to be able to see it when you put it in there, but you also want to see if it fuses over time. And you want to see what happens to it so that if there is migration of the implant, I think it's really helpful to be able to see that. And then finally, cost. We have to think about that always. And so as we start to think about some of these interbody cages, you want one that will maintain segmental lordosis, foraminal height restoration, again, favorable imaging. I think placement and assessing fusion is super important. And this is an early 3D printed cage that you can see on there that I put in, but it was a big one. The patient needed one though, and so that's where I think expandables can be really helpful. And then the subsidence issue. If you put any cage you put in with poor end plate preparation will subside. And depending on how you do it and sort of your workflow, you can also sort of predispose that cage to subsiding. So you have to be really careful with that. And then obviously have it be safe. And I think as we move more towards MIS and endoscopic procedures, I think having cages that can expand not only in height but lordosis and maybe even horizontally could be really relevant to spine surgery as we move along in the next 10 to 20 years. This is an example of a PEEK cage that you can see, an example of a silicon nitride cage, and then finally this 3D printed, and then onto an expandable cage as well. So really, all of these sort of fall into the same categories, and all of these have properties that we like and that we can fill graft, we can see through it. It's a lot of favorable qualities to all these materials, but I really think that the 3D printed and or expandable is sort of the cage that most of us use now, and definitely is the workhorse for me. And so are these realistic goals, though? As we think about this, with subsidence, I think that we always have to continue to consider that with these expandable options, because you'll see in some studies I show you that they like to subside. Here's a modulus of elasticity sort of schematic that Wellington showed as well. Silicon nitride is high, and as you go down, old school titanium, PEEK, and then cortical bone. And so we're trying to sort of, find the sweet spot there. But in reality, when you look at this study, this biomechanics study, looking at lower density, and this was a foam model, lower density foam versus higher density foam, small cage footprints versus bigger cage footprints, you can see here that as obviously the lower density foam with small cages is not favorable. But it doesn't really matter what the material is in this particular study, PEEK, silicon nitride, or titanium. They all sort of performed equally. And obviously, in somebody who's osteoporotic, you want to maximize your surface area. And so cage morphology matters, but the composition might not necessarily, but you have to do a good end plate prep. This is the first study sort of looking at expandable versus static T-lifts. This was a study out of Harvard in 2025, a spine journal, and they looked at 417 patients with a mean age of 62, I think a pretty relevant population that we all see. 306 were static cages versus 111 expandable. And what they showed at 2 weeks and 6 months was that expandable cages did have increased disc height, 1.1 millimeters, which seems difficult to sort of measure, especially with our current systems, but still a study reported. And it didn't really change from 2 weeks to 6 months, but at 1 year, they changed a lot. There was no differences, and this was all due to subsidence through this expandable cage, 14% subsidence versus 6%, and I think that's where we see the differences. And as we sort of think about this study now, you kind of think about this patient, and these were a couple examples. The top version, the cage is pretty anterior, and then you can see it subside through that superior end plate of L5. The lower image here, you can kind of see that expandable cage, and that was a static cage on the top, expandable cage on the bottom. You can see the L4 sort of retrolesthesed on L5 as that cage collapsed and developed into some recurrent foraminal stenosis. And so obviously, these are all things that happen. We try to minimize those, and I'll show you some of my own patients in that, where we can see, I'm going to show successes, obviously. I'm not going to show my failures, but show successes. And I think the reason why they were successful we'll go through. But this is sort of the data on this 2-week change, 6-month change, and then no difference. As I think about the next case, this is a 60-year-old male presented and feeling very pitched forward with neurogenic symptoms. He had right greater than left L5 radicular symptoms. He was a healthy pickleballer. He's proud of that. And was intact on exam, but as he got up and moved around a lot, he would start to develop a little bit of a foot drop, and so it really bothered his mobility on the court. So he came in for an evaluation, and as you can see, he's got an L4-5 degenerative spondylolisthesis with some kyphosis and kind of a grade 1. As you sort of look at the flexion and extension views, it doesn't change very much. He's pretty flat, And as you look at his scoliofilm, again, he's pretty flat through his lumbar spine, and it's likely secondary to just how much stenosis he has. He has a big cranially extruded disc fragment as well, and he's probably sort of listing in a forward pitched position so that he doesn't pinch his nerve roots off. And so this is a patient where I think a good indication for L4-5 decompression and fusion. Here he is on the table. Hasn't changed much, but you can see his kyphosis is relaxing a little bit. And then as I put in screws, and my workflow is I put in screws and try to reduce the deformity. It makes my decompression a lot easier when I do it that way. So I'll try to reduce the deformity, which you can see we're starting to get there a little bit just with some relaxation. And then when I put the rod in, you can pull that L4 vertebrae back. And this was the way I used to do it, and then I'll just go through the workflow of how I do it now. And this is a little bit of distraction through that L4-5 level, which helped with not only the reduction of the spondy, but then also the kyphotic deformity. And then as I put the interbody cage in, I would compress posteriorly to seat that cage anteriorly and create some lordosis through that segment. As you can see, that expandable cage was sitting on the end plates pretty nicely. I did not feel as though I had any end plate perforations, but as you can see in his initial upright films, he's already subsided a little bit. He has good lordotic restoration. He had an excellent overall clinical result in that his symptoms were improved in regard to his neurologic symptoms. But then as we followed him over time, you could see some continued subsidence, still improved lordosis, but did have some end plate perforation and some back pain that maybe this is related to or not. But you can see here his lordosis is now markedly improved from his pre, which was about 2 degrees of kyphosis, to about 12 degrees of lordosis. So still good, but subsidence. So we have to keep an eye on that, and it's always annoying when you see that. But so then we get into this next study, which shows, and this is an open TLIF study. This is a matched cohort study, 15 each group, and again, similar to what I just showed you in that last case, is that the patient with an expandable cage did have improved segmental lordosis post-op, 5.3 versus 1.6, and then at final follow-up, 5.7 versus 1. There were no differences in intra or perioperative complications. They did do a little bit of speculation here, and I put it in here just because they also had it in there, that it was less likely to require readmission, develop adjacent segment disease, or require revision surgery, and one would argue 1.7 years is definitely not enough to make any of those, at least the latter two statements. And so here's the sort of data that you can see here. The segmental lordosis is markedly improved. And then at final follow-up, you can see there's no change, but that's from post-op to final follow-up, so there wasn't a lot of subsidence that occurred. And then this is another study. Now this is an MIS TLIF study, which is really differentiating two different kinds of cage designs. This is 149 patients. 40 were in the height cage, which means it just expands in height but not lordosis. And 109 were in the HL group, where it's height and lordosis. They were all expandable MIS TLIFs, and the height and lordosis one, as you would expect, showed improved segmental lordosis, improved disc angle, but the early subsidence was very high at 23%. It did improve, which they talk about a learning curve in regard to this, and I would agree with that. I think there is one, but still pretty high, 18% after the first 20 cases. And these are the different cage designs, and lots of them will have variable lordotic designs, and so this one in particular was just a parallel distraction versus a lordotic distraction. And you can see here the difference is, excellent height and lordotic restoration, but then also one that had a pretty significant failure. And you never want to see that. That's always a nightmare if that comes into clinic after surgery, because those patients actually usually aren't doing that well. And so that's a failure from their paper as well. And so let's get back to our case. This is that 85-year-old female. This is a patient that I did about 6 months ago. Again, L4 redic, neurogenic claudication, active. This is the L4-5 grade 2 spondy. stenosis. And again, these are some intraoperative radiographs. You can see spondy hasn't reduced very much initially. You start to take facets down a little bit. You put screws and rods in. Again, I do the same thing where I reduce the deformity, decompress, and then as I distract slightly through there, you can keep that lordotic restoration. And then the way I do it now is I just put the cage in and I expand it out as much as I can, and I don't do any compression posteriorly anymore, and I think that has helped with some of my subsidence issues. And you can see the foraminal height restoration and lordotic segmental lordosis restoration. And this is immediate post-op, and then now 6 months out, and the cage still looks good despite it being in an 85-year-old female. This is another patient, 66-year-old male with renal cell carcinoma. The reason why I'm showing this case is just to show a different cage design. You can see a large tumor invading his spinal canal, known renal cell, and this is a patient where I'll use an expandable banana-shaped cage to improve my fusion area and footprint, and I think that that's also a great option, especially at 5'1", where you need that extra level of surface area to help decrease your subsidence issues. And so in conclusion, expandables are here to stay. There's pros and cons with everything we do. I think operative technique is extremely important in developing a workflow that works for you. You cannot, end plate prep is the most important in any of these patients. And again, I think it is a more technically demanding surgery when you use these materials. And then MIS endoscopic applications will continue to evolve. And really, as they evolve, the ability to place a small cage and expand it not only up, but then horizontally out will be helpful for these endoscopic applications, but those cages are very expensive now. We need to continue to consider that, and establishing relationships with not only industry, but having the hospital system also help with this can be helpful in getting these products into our systems. So thank you very much.